Okay, let's get started. Hello, everyone. Here we are together again for the MSK case presentation series. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank everyone for tuning in today. My name is Aline Serfati, and I'm here with my colleague, Dr. Hilary Humans, who coordinates this series with me, as well as our guest speakers, Dr. Marcelo Nogueira, Dr. Marcelo Bordalo, Dr. Winston Rennie, and Dr. Robert Lambert. Before we begin, I want to let you know that the presentations today will be recorded and will be available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. For those of you who are unfamiliar with OCAD, it is a knowledge sharing forum where members post challenging cases on a daily basis and count on each other to help solve these difficult cases. To have access to this cutting-edge MSK content, please consider registering on the OCAD website. Before we get started with the presentations, I want to let you all know that we will have a break in July and we'll resume at the end of August with a session focused on tumor and pseudotumor lesions. Now back to our presentations. The speakers today will present their cases, and at the end we will have a Q&A session. So if you have questions at any time during the presentations, please put them in the chat box, and at the end the speakers will respond to them. Just a reminder, attendees have not been given the permission to stream or record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without the permission from the speaker is illegal. We thank you for your understanding, and without further ado, I will kick off the session. We have the pleasure of having Dr. Marcelo Nogueira Barbosa join us today. So he is an associate professor of radiology at Ribeirão Preto Medical School at the University of São Paulo. He graduated with a degree in medicine from the University of São Paulo and completed a research fellowship in MSK imaging at the University of California, San Diego. In 2003, he received his PhD in medical science from Ribeirão Preto Medical School. His clinical and research interests in MSK imaging are the spine, osteoporosis, and peripheral nerve imaging. He has a special interest in quantitative investigation techniques, especially MRI and computational imaging process techniques. Please, Marcelo, take it away.
Good afternoon. Thank you so much, Aline, for your invitation and for the introduction. I apologize. I'm just in the middle of a meeting, MSK meeting from São Paulo State Society of Radiology. And it's a big pleasure to be with you here today. And I thank also to OCAD. I will present a case that was very challenging for me. I will first show this index case. It was a 18 years old female that presented on physical exam and on radiographies as multiple joint deformities, multiple subluxations, osteopenia, and without marked erosions, without bone destruction. This patient had the previous history of since 2 years old of progressive joint deformities and pain, early onset of muscle weakness, dry skin, multiple lentiginous and hypochromic macular lesions. And the feet, we also saw deformities and luxation of the first metatarsophalangeal joint, and in the elbows we could see soft tissue calcification in the region of the close to the insertion of the biceps tendon bilaterally. This patient also developed during the evolution of the case with multiple skin lesions that were very suspicious for psoriasis, and biopsy confirmed the diagnosis of psoriasis. I followed this patient in discussion sessions, multidisciplinary discussion sessions for several years. And in 2006, the diagnosis was juvenile idiopathic arthritis, subform psoriatic arthritis. Both clinically and radiologically, we were comfortable at that time with this diagnosis. But this patient used along the years several drugs, etanercept, infliximab, methotrexate, leflunomide, and the response to the drugs was never good enough, was not good at all. In July 2009, patient lost incisor teeth, and we performed a couple of times ultrasonography of her joints. In our hospital, usually patients with JIA are evaluated mostly with ultrasonography. And this patient didn't show synovial hypertrophy or just mild findings. Because of that, we evaluated with MRI, and also we didn't find quite important inflammatory changes like synovial hypertrophy. And interestingly, most of the time, her ASR and CRP values were within the normal intervals. Some imaging findings were also unexpected, like basal ganglia calcification and dental abnormalities. So, because of the history of some of her relatives, we started to search for findings and this is the first companion case that in fact is the mother of the index case patient. We can see many joint deformities, polyarthropathy, deforming polyarthropathy with multiple subluxations. There are some arthroplasty previously performed here, and also multiple joint subluxations. And on the knees and hips and foot, also many soft tissue calcification and tissue calcifications everywhere. And her mother, the mother of the index case, had complete dental loss at the time she was investigated. The second companion case is the aunt of the index patient. And she also showed osteopenia and many soft tissue calcifications, again, especially in incisal sites. Her aunt also lost almost all the teeth and showed mild basal ganglia calcification and also cardiac valve calcifications. So the patient of the family of this patient was investigated, and the individuals marked in red here, all then had chronic deforming polyarthropathy, psoriasis, and dental loss. And the yellow ones that are marked in yellow also had chronic deforming polyarthropathy. So a genetic investigation was performed in this family. And in fact, it was an MDA5 related type 1 interferonopathy. Type 1 interferonopathies are a disturbance of homeostatic control of type 1 interferon, signaling due to Mendelian mutations. And the title of this paper that included this family and another family from other country, the authors highlighted like a mimic of Jacquard's arthropathy because in fact, if we apply the criteria for Jacquard's arthropathy-like deformities, those patients will fit in. In this companion case, besides the already shown multiple deformities and subluxations, we can also see acro-osteolysis, osteitis, and bone resorption, like in this pencil in a cup appearance and deformity. So this family could be included in the Singleton-Merten syndrome, that is this type of type 1 interferonopathy, but see that there are many other type 1 interferonopathies, including systemic lupus erythematosus. So Singleton-Merten syndrome is an upregulation of IFN. It's an autosomal dominant mutation in MDA5. And differently from other type 1 interferonopathies, these patients usually have significant musculoskeletal involvement. Deforming polyarthropathy, psoriasis, dental abnormalities, cardiac valve involvement, glaucoma, and basal ganglia calcification are mostly seen. So this patient was treated for many years as psoriasis and psoriatic arthritis wrongly. When should we suspect that rheumatologic diseases are being mimicked by other congenital diseases? Some disease in more than one family member, but especially if 2 or more dysmorphic findings are present, absence of autoantibodies, absence of synovial or at least significant synovial inflammation on physical exam and on diagnostic imaging, as in this case, normal inflammatory activity, and poor response to recommended treatment. Nowadays, the innate immunity errors are included in a spectrum of diseases that in one pole lies the autoinflammatory disease, and in the other pole, the pure autoimmune disease. Many of the diseases we radiologists deal with are in the middle, in between, like rheumatoid arthritis and spondylitis. Type 1 interferonopathies, especially this type of, in this case of Singleton-Merten disease, tend more to be in the pole of autoinflammatory disease. But these patients also have varying degrees of autoimmunity and or immunodeficiency. So take-home messages. I got general learning with this case that inborn errors of immunity include also autoinflammatory disease that don't show autoantibodies. And we need to search closely for that when disproportionate signs of inflammation or we don't have signs of inflammation, or it's disproportionate with the progress in structural damage like we saw in this patient. And also, of course, a specific learning. If I cross again with all this constellation of findings, deforming polyarthropathy, psoriasis, dental abnormalities, cardiac valve, and basal ganglia calcification, I should at least think about putting the differential, this Singleton-Merten disease, this type 1 interferonopathy. I try to teach to my medical residents that I'm not worried when I don't know a rare syndrome unless radiology findings are critical for this diagnosis. If at the time we started following this patient and discussing in multidisciplinary meetings, I knew this syndrome, everything would be easier for me. So that's a challenging case that I share with you, and in that we did several mistakes along the years.
Thank you, Marcelo. Beautiful and a very rare case.
Okay.
I can't hear you.
Right.
Hillary.
Thanks. Good morning, everybody. I'm Dr. Hillary Humans. It's my pleasure to introduce my good friend, Dr. Winston Rennie, who is a clinical musculoskeletal radiologist at the Leicester Royal Infirmary in the UK since 2005. He has focused his practice on using MRI, CT, and ultrasound modalities in the investigation of musculoskeletal disorders. He is particularly focused on rheumatologic and orthopedic disorders, focusing on seronegative spondyloarthropathy with MR imaging and ultrasound. These are paramount in his practice. His research interests are on maximizing the utility of MRI in diagnosis and treatment, follow-up of spondyloarthropathy. He's published and presented extensively on this topic. And he has served as the vice chair of the ESSR Arthritis Subcommittee. He regularly lectures and hands-on workshops, both domestically and internationally, for rheumatologists and radiologists in London and throughout the world, for multiple international societies, including the ESSR, BSSR, and ISS, promoting the use of MRI in the early diagnosis of spondyloarthropathy, along with his mentor and dear friend, Professor Lambert, who is with us today. This spondyloarthropathy and its early recognition has become a lifelong project for him, and promoting awareness on the advances in the field, both to fellow radiologists and rheumatology colleagues, is his passion. Take it away, Winston.
I can't hear him. I can hear you, Winston. You're muted.
Unmute my audio. Can you hear me now?
Yeah.
Yes.
Fantastic. So
Can you go to presentation mode?
yeah, but the problem is I have my my button on top of the presentation mode, so I'll have to find a way to play this without this is great. Well, I can't go to presentation mode for some reason. This OCAD, but the menu seems to be sitting on top of my keynote presentation. So I am desperately trying to play it, but I can't play it. So I'll have to go through it in this mode, unfortunately. Yeah. So this is my presentation today. It's about unusual cases in osteoporosis. I would first like to thank Professor Giuseppe Guglielmi, who's a past president of the ESSR, who's written quite a lot on this field, and I will talk to you about it later, what the case is. My good friends, Professor Morty, who's one of our rheumatologists, and Dr. Amit Shah, who's right in the center, who's a radiology colleague of mine, who's helped with the cases. That is King Alfred the Great of England, who I will talk to you about later in the talk. Now, the first thing first is mushroom treatment. It's what most radiologists get. We're kept in the dark and fed on very little clinical information, much like this decomposing material over here. But this wasn't the case in the first case that I'm going to present to you. The first case is of a 47-year-old white Caucasian male who presented to our rheumatology services with an 18-month history of recurrent back pain. It seemed inflammatory in nature, but there was some mechanical component to it, which has been progressively increasing and now is virtually continuous. He also had a history of unexpected weight loss. He was HLA-B27 positive, and on physical examination, he had a reduced spinal movement and a point tenderness over sacroiliac joints. So the rheumatologist made a clinical diagnosis of axial spondyloarthropathy, which was suspected, and they organized and requested an extended field of view MRI, which we perform in Leicester, of the entire spine and the sacroiliac joints. On the MR of the spine, lesions were picked up, and I won't quite present to you the way it was done, but I will show you the chest X-ray, which we performed after the MRI. So the chest X-ray demonstrates a radio-dense lesion, which is not dense enough to completely obscure the underlying ribs, and the lung parenchyma can just be seen through it. It is present in the apical region, as on the arrow. On the CT chest with contrast, you can see a mushroom-shaped lesion, which I've drawn the mushroom on, which is sitting in the rib with expansion of the rib and the destruction of the cortical margin. Now, the next slide will show you that it is an MRI with post-contrast images, a T1 fat suppressed post-contrast image, which shows entire diffuse enhancement of the lesion with expansion of the rib and an area of low signal intensity, which does not enhance, which you can see on the T2 weighted image as a solid lesion with solid enhancement and expansion of the rib. This mushroom-shaped lesion is extending into the pleura, displacing the lung parenchyma at that site. Go on to look at his MR of the sacroiliac joints, and you can see on the axial T1 weighted image that there are areas of sclerosis which are symmetrical, extending into both sacral ala, as pointed out by these arrows, which demonstrate sacral insufficiency fractures. Here we have diffusion weighted imaging with a post-contrast sagittal parasagittal image going through the lesion, which shows increased enhancement within the rib with this large soft tissue mass extending and displacing the lung parenchyma. There is virtual complete enhancement of the mass with a brim of calcium there, which you can see on the radiograph. That does not enhance. Diffusion weighted imaging and an ADC map over here demonstrate restricted diffusion in keeping with solid tissue elements. The patient went on, progressed to have a CT guided biopsy of the lesion, which was successful, and was referred to the thoracic surgeons who resected this lesion. So you can see the resection up here with the missing rib. The second follow-up case is of an Indian patient from the Indian subcontinent, of which there are many of us in Leicester, who presented with vitamin D deficiency, malnutrition, multiple low trauma fractures, and a low calcium. Now you can see those established fractures of the femoral necks with a varus type of deformity that has occurred because of these established fractures, and those astute amongst you might see a transverse fracture across the superior acetabular margin on the right. He also had multiple sacral fractures, and there were fractures everywhere. A DEXA scan was performed, and interestingly, the DEXA came back as normal. And this is quite common in this disease. Whilst he was having a bone workup, one of the samples that was requested was of a particular substance called FGF23, which is fibroblast growth factor 23, and it came up as grossly abnormal at the level of 2,500, which was consistent with oncogenic osteomalacia. Now, because of this statement, a PET CT was performed, and the PET CT was vastly unremarkable, except for this finding, which I will show you in retrospect. In retrospect, there was a finding of incidental increased uptake in the forearms on both sides, but I would like to draw your eye to the one on the right over here. This was deemed to be artifactual due to pooling of radionuclide. Subsequently, 2 years later, he presented to our sarcoma clinic with a mass in the forearm. Radiographs were performed, and the radiographs demonstrate this sort of fluffy periosteal reaction with a rounded or a spherical lesion that you can just about make out, which is a soft tissue mass distinctly displacing the soft tissues in the forearm. The periosteal reaction is primarily along the radius and along the ulnar border of the radius. And you can see that there. An MRI was performed, and on on the left, you can see a stir sequence, and on the right is a T2 weighted sequence, and you can appreciate that the patient is extremely malnourished by the lack of subcutaneous fat and the fact that the muscle shows a sort of grayish signal intensity on the fat suppressed images. Albeit the major lesion is centered completely around the radius, encompassing the radius and circling it, with areas of low to intermediate and high signal intensity on the T2 weighted images. It's infiltrative, and it doesn't destroy the cortex, except there is a bit of a periosteal reaction. When you look at the post-contrast MRI, and these are the 3 selected images from the post-contrast MRI, you can see diffuse enhancement of a large extraosseous mass with a small foci of fibrous tissue and a similar type of appearance as to the other lesion, as these tendrils of fibrous tissue extending into the large soft tissue mass. Again, this is a transverse image demonstrating the same thing, with fairly uniform diffuse enhancement. Went on to perform an ultrasound guided biopsy, and the ultrasound guided biopsy was taken with and this is the same orientation, and it demonstrated bland spindle cells with a grungy type of calcification pattern, right? The chromogenic in situ hybridization test, which is quite a mouthful, called a SISH test or a FISH test, which is a fluorescent version of it, was strongly positive for FGF23 mRNA. And that was diagnosed as a phosphateric mesenchymal tumor, which was all these mushroom-shaped lesions. So phosphateric mesenchymal tumors are rare tumors. They are associated with tumor-induced osteomalacia. They secrete a substance, a peptide hormone, which is called fibroblast growth factor 23, and produce a sort of paraneoplastic type syndrome with a decrease in proximal tubule reabsorption of phosphate. This in turn inhibits alpha-1 hydroxylase, which is an enzyme that is responsible for vitamin D3 production, and thereby reducing vitamin D3, causing osteomalacia. Most of the seminal work was done by Giuseppe Guglielmi, and most of these tumors are found in the craniofacial sinuses, but now have been discovered in nearly every other part of the body. What are the pathogenic mechanisms that produce hyperphosphatemia? Pathogenic mechanisms are an inadequate phosphate intake, which are all these conditions, an intracellular phosphate shift, which are due to all these conditions, and an increased excretion of phosphate in the urine, which is really what we are focused on, which is hyperparathyroidism, tumors, and vitamin D deficiency. With phosphateric mesenchymal tumors, you can get what's called hyperphosphatemic osteomalacia, or otherwise known as tumor-induced osteomalacia. Finding the source of this tumor is critical, and resection of this tumor is curative of the condition in its entirety. The important differential diagnoses that one should look for are crystal arthritis, synovial sarcoma, metastasis, and paraneoplastic syndromes. And of these, the common ones are crystal arthritis and synovial sarcoma. So I'll just give you a quick example of a Milwaukee shoulder, which is a type of destructive crystal arthropathy. Again, looks like a mushroom. So I've been going on and on about mushrooms, and the topic was really to tell you what these red and white toadstools are. They're called fly agaric. They're extremely toxic to humans, so please don't eat them, even though they're extremely hallucinogenic. They're related to Christmas in a funny sort of way, because the mushrooms are eaten by reindeer, which then think they can fly and stagger about looking like they can fly and fall off cliffs. Reindeer cause yellow snow because they excrete the hallucinogen, which is now non-toxic and can be eaten by a shaman who dresses very similarly in Finland to Father Christmas and flying reindeer. So you see how fly agaric is related to Christmas. Now, coming back to the whole thing about the learning points from this were that if you get tumor-induced osteomalacia or hyperphosphatemic osteomalacia and unexplained low trauma fractures in roughly the 3rd decade, make sure you check or get your smart clinician to check for fibroblast growth factor 23 in their bone profile workup. Use gallium-68 dotatate and dotanoic PET-CT to localize this lesion. So effectively use some sort of functional imaging to try and localize the lesion. Look very carefully for it because it can be anywhere, not just the cranial sinuses. Once you've located the lesion, characterize it with your radiographs, your CT, and ultrasound biopsy it. With that, I'd like to say thank you and leave you with King Alfred's cakes, which are a type of fungus again. And there's a famous story of King Alfred burning his cakes, just like I burnt mine without being able to present this in a presenting mode. Thank you very much for having me, and I hope you learned something from it.
We certainly learned a lot. Thank you so much for your presentation. Okay. Our next speaker is Dr. Marcelo Bordalo. He is the Director of Musculoskeletal Imaging at Hospital das Clínicas at the University of São Paulo, and also the Director of MSK Imaging at Hospital Sírio-Libanês, both in São Paulo. He graduated with a degree in medicine from the University of São Paulo, where he also completed his radiology residency, his MSK fellowship, and his PhD. Additionally, he completed an MSK fellowship at the Université Catholique de Louvain and Hospital for Joint Disease in New York City. He's a member of the ISS and leads the South America ISS Outreach Program. He has authored and co-authored several book chapters and numerous peer-reviewed articles. And in addition to all that, he's a very good friend of mine, and I'm very glad to have him here today. Marcelo, take it away. I can't hear you, Marcelo. I think you're muted.
I'm sorry. Now here I am. I'm gonna share.
Did
the
you
screen.
hear me?
Yes, I heard you.
Okay.
I'm sorry. Okay, so thank you, Aline, for your kind introduction. Thank you, Hillary, for the invitation as well. It's an honor to speak here at the MSK presentation series. I have no disclosures, and my index case here is about a 94-year-old female, and she has acute dorsal pain in paraparesis in the inferior limbs. That is after falling from standing position 1 month prior now. So she performed this MR of the thoracic spine, and we see here on T1 weighted image, this sagittal T1 weighted image, some irregularities at the vertebral bodies. And we can see on fluid sensitive sequences, this high signal intensity within the disc, and also the irregularities of the vertebral body are better depicted. We can also see this high signal intensity, this edema on the adjacent vertebral bodies, and there is little soft tissue edema surrounding. Also, we can see here some compression at the spinal cord at this level and some increased signal within the spinal cord, which is compressive myelopathy. So the primary differential diagnosis are extensive degenerative changes with especially MODIC 1 because of the edema and infection. However, there are some issues here. First, the clinical history. The patient had abrupt symptoms after a trauma, a minor trauma. She fell from standing position. Also, if we look at the T2 weighted image, there is large disc and large vertebral changes and very few soft tissue changes. And that is thinking of an infection, which was actually the first differential diagnosis for this case. And also there are other findings in the spine. We can see this hyperkyphosis, we can see discs with high signal on T1 weighted images here. We can see vertebral squaring, and we can see these syndesmophytes here. And also on axial images, we could see this costovertebral ankylosis associated with all the other findings. So these are typical radiologic signs, imaging signs for ankylosing spondylitis. Because of that, CT was performed, and we can better depict the extense syndesmophytes, and also we can see here posteriorly better these ankylosis of the spinal processes here. If we take a closer look at the level of the abnormality on MR, we can see that there is a discontinuity on the syndesmophyte anteriorly at the disc level. And if we go to the posterior elements, we can see these fractures of the posterior elements here. So in the setting of ankylosing spondylitis, CT helped a lot to see that there is a transdiscal fracture. So this is a companion case. It's a 47-year-old female. She had pain in the cervical spine, and she did chiropractic treatment because of this pain. And unfortunately, she dramatically developed quadriplegia after the session, and she went to the ER. The dramatic CT of the cervical spine gives us no doubt about the fracture, and we can see this angulation here. The first question I would like to put in here is, what is the radiologist's role after a diagnosis of a spinal fracture on CT? First is describe the type of fracture, eventually classify the most used classification for cervical spine fractures is the AO. I'm not going to discuss this in this presentation. And also describe any findings associated with the spine fracture. If we look at here, the first impression is that there is a vertebral body missing. So we given the suspicion of a burst fracture of C6, the first thing we have to look on a spine examination is look for the pedicles to localize, which vertebral body we're dealing with. If we look here at the whole setting of sagittal images, we can see that there's a pedicle here, there's a pedicle in the vertebral body below, but there's no pedicle in between them. And the same thing on the other side. There's a pedicle here, a pedicle in the vertebral body below, but no pedicle in between. Here, just to summarize what we saw in the examination. So this, in fact, is a transdiscal fracture at the C5, C6 level. Okay, we can see some associated findings here, especially the ankylosis of the apophyseal processes on both sides here. And we can see also these extensive syndesmophytes anteriorly and also squaring of the vertebral bodies. If the CT of the whole spine of this patient, we can see the extensive syndesmophytes anteriorly, the squaring, some degree of calcification and ossification on the disc, intervertebral discs as well. So this is classical bamboo spine in the setting of ankylosing spondylitis. Then we can see the ankylosis of the sacroiliac joints as well in this patient. So fractures in a rigid spine. The rigid spine is characterized by ankylosing spondylitis, DISH, diffuse idiopathic skeletal hyperostosis, degenerative spondylosis, and also surgically fused spine. The ankylosing spondylitis has a 7 times more chance to fracture, and this risk increases with the length of the ankylosed spine. We must think of the rigid spine as a long liver arm, just like a long bone, just like a femur, a humerus, for example. And one teaching point I would like to point out is that fractures in these patients of ankylosing spondylitis occur through the disc, which is the weakest link in the ankylosed spine. There's a 20% risk of multiple non-contiguous multiple fractures here. As we see in this case from the literature, we can see this fracture at the cervical thoracic transition and also a fracture here at the thoracic spine. So always look for other fractures when we see one fracture at a rigid spine. The most common combinations are cervical and thoracic, and the other one is thoracic and lumbar. So why does the ankylosing spondylitis spine fracture? First, the spine works, as I said, along lever arm, just like a long bone. And also, these patients develop osteoporosis. Actually, 60% approximately of the patients with ankylosing spondylitis. So severe fractures can occur with minimal trauma. We must keep that in mind to always raise the suspicion of a fracture in a rigid spine. So there is a delay in diagnosis of the fracture in a rigid spine that occur in 20 or 50%, in 20 to 50% of cases of the rigid spine fractures. Why is there this delay? First, the imaging findings are more difficult. There are deformities, there are extensive dystrophic bone changes. The fractures occur at transitional zones. Also, patients do not recognize signs of acute injury because many patients with AES deal with chronic pain and making acute fracture pain difficult to distinguish from the chronic one. Also, the lack of high impact trauma may decrease the suspicion for the fracture by the clinicians. And the main problem in delaying this diagnosis is secondary decline in neurologic function because of this delay. And this occurs in 80% of the cases, the decline in neurologic function because of delay in diagnosis. So it's important for us to make the diagnosis as early as possible. CT is the examination of choice, and when to perform MRI in this setting of trauma in a rigid spine. First, in acute fractures in CT, and there's a high suspicion of a fracture in a rigid spine, MR can assess posterior ligamentous complex, and also to confirm spinal cord compression. This is the MR of our patient. We can see here that there is extensive myelopathy in this patient. This is a case of a dish. They had this large ossifications of the anterior longitudinal ligaments of the spine. He had a minor trauma. He fell from standing and he developed a C6 vertebral body transverse fracture. So in dish patients, the fractures more often occur through the vertebral bodies because the degree of anterior ossification is higher at the intervertebral disc and lower at the vertebral level. So which makes the vertebral body the weak link and has a higher risk for fracture in these patients. There are some other cases. This other cases was initially interpreted as infection. Here we can see this high signal intensity here and irregularities of the vertebral bodies, the high signal intensity at the disc level here. And CT, it's easier to see. We can see the fracture and posterior elements going through the disc of this patient. So this is a transdiscal fracture, another transdiscal fracture. Another case, we can see L5S1 transdiscal fracture in the setting of ankylosing spondylitis. He had all the signals, squaring, syndesmophytes, SI joints, ankylosis as well. So the take-home messages are delayed diagnosis occur in 20 to 50% of fractures of the rigid spine. The rigid spine with acute back pain or trauma must be considered with high suspicion for a fracture until proven otherwise. Fractures in the rigid spine can occur with minimal trauma, and CT is the examination of choice, and MR is reserved for evaluation of acute fractures and or spinal cord compression. So it is our role to recognize the imaging features of a rigid spine and look for subtle fractures. Also, look for the fractures in other points. In ankylosis spondylitis, the transdiscal fracture is the most common feature, and at DISH, the vertebral fracture is the most common feature. And there's a 20% chance, as I said, of having non-contiguous multiple fractures. Thank you very much.
Thank you, Marcelo. That was a crazy case. Thanks. It's now my pleasure to introduce my friend Robert Lambert. Dr. Lambert graduated from Queen's University in Belfast, Northern Ireland, UK in 1980. He did his radiology residency in Belfast and a 2-year musculoskeletal radiology fellowship in Toronto, Ontario, Canada. He holds fellowships in the Royal College of Radiologists of the UK and the Royal College of Physicians of Canada. Dr. Lambert was head of musculoskeletal radiology at the University of Alberta from 1989 to 2002 and department chair from 2002 to 2016. His primary research interests are MSK, MRI, and imaging of arthritis. He's published over 140 peer-reviewed articles, 5 book chapters, and more than 300 abstracts. He's a member of many international societies related to musculoskeletal radiology and arthritis research. Okay, Rob, please share your screen.
Thank you very much. No, where's the, oh, here we go. Whoops, sorry, I just have to move that. Good morning, everybody, or for some of you, it may already be afternoon. It's my very great pleasure to be invited to talk to you for a few minutes today about a couple of interesting cases and my great appreciation to the organizers of these wonderful sessions. So the first case I'm going to talk to you about is that of a 26-year-old man. He presented to his general practitioner with a 1-week history of right knee pain. There was no history of trauma. He was otherwise completely well and had no other prior medical history, certainly that we were aware of. His physical examination was reported to be unremarkable. And so he started off having some radiographs of the knee. And here we see 3 radiographs, the AP tunnel and lateral view. And there's a radiolucent lesion in the medial femoral condyle here, which is probably best of all seen on the lateral projection with a faint sclerotic border here. And on the tunnel projection, and the medial border of the lesion is less well visualized. There's possibly a small effusion. There's no definite mineralization within the lesion. The joint spaces are preserved. And not knowing what this lesion was being caused by, with no prior history of trauma, we proceeded to perform an MRI scan. So here's the MRI scan that was performed. I'm going to show you a series of images. First of all, these are the proton density weighted images. And we see here a well-defined lesion with sharp borders. In some areas, the borders are quite sclerotic, confirming that the lesion is not acute and has a relatively benign appearance. There is soft tissue extension into the intercondylar region, and we see abnormal soft tissue swelling surrounding the anterior cruciate ligament. These are sagittal T2 gradient echo sequences with fat saturation, and we see on this sequence that there is some heterogeneity of signal within the lesion, but it retains its very sharp border, just very subtle bone marrow edema associated, the soft tissue swelling around the ACL, and he has a small joint effusion. However, within the synovial fluid, we don't see any abnormality, and we don't see evidence of synovial thickening or other changes of the synovium. Some coronal proton density images just confirm the intraosseous nature of a component of the lesion, but there's a break in the medial cortex here, and we see the continuity with the intercondylar soft tissue mass. Some more sequences show on T2 that the soft tissue mass and the intraosseous lesion are predominantly very low signal intensity, and some more water-sensitive sequences confirm there's just a little bit of bone marrow edema in the bone, but very little intermediate weight signaling of the soft tissue mass. So based on the plain radiographs and MRI findings, it was hard to be certain whether this was a bony lesion that was extending into the soft tissues or a soft tissue lesion that was extending into the bone. The bony lesion appeared to be slightly larger than the soft tissue component, but they were relatively similar in size. And so we were considering a differential of a chondroblastoma or giant cell tumor. We felt that the giant cell tumor would be less likely and the chondroblastoma more likely. Synovial diseases such as PVNS or synovial chondromatosis, although there wasn't very much blooming. There was some heterogeneity of soft tissue signal, but not the typical blooming that we see with PVNS, and also depositional disorders. But the patient was only 26 years old and was healthy, so these were considered to be significantly less likely. I'm afraid a yellow box has appeared on my screen and I can't get rid of it. My apologies for that. A CT guided biopsy was then performed, and during the CT guided biopsy, we discovered that there is a very small amount of mineralization within the lesion, which was consistent with calcification. And the biopsy material came back showing large deposits of amorphous material with some histiocytes and some giant cells. And this material was typical for tophaceous gout. So subsequent blood tests revealed that he had hyperuricemia and that he had normal renal function, and he was found to be hypertensive, although this was unknown at the time of the presentation of his deep pain. I'm going to show you now a companion case of an intraarticular knee mass. And in this situation, the patient was a 67-year-old man with chronic knee pain, which he'd had for a while, and he was referred for an MRI scan for possible meniscal tear. His physical examination was reported to be unremarkable, and he had no other relevant medical history. And here on the initial radiograph, there's very little to find. He has a small effusion, but otherwise the radiograph appears completely normal. The MRI scan, and here I show you only 2 images because the findings were very subtle, and in fact the MRI scan was reported as normal. But he does have a subtle soft tissue mass surrounding the popliteus tendon and possible very subtle scalloping of the lateral border of the lateral condyle there. But these findings were not identified at the time of the original scan, which, as I say, was reported normal. And there's certainly no evidence of internal derangement, which was the focus with the examination, looking for meniscal tears, ligament tears, and articular surface arthropathy. So he soldiers on for some years and has intermittent pain, but he has no other signs of arthropathy. And again, as far as we're aware, he's otherwise well. And then he has a repeat MRI 5.5 years later. And now we see that this soft tissue mass has enlarged somewhat. The scalloping of the bone is a little larger, and he has this faint, just very subtle area of bone marrow edema, but it's really quite subtle, although the soft tissue swelling is more prominent. At this point in time, the differential certainly included tophaceous gout, although he had no other findings of gout anywhere else in the body or clinically. So what we did first of all was repeat the radiographs. And at this point in time, again, the radiographs are remarkably normal. He does have a little bit of soft tissue swelling here, and there may be some very, very faint calcification, but it's extremely hard to identify those findings on the radiograph, which is near normal. We went on to confirm the diagnosis in this case in 2017. By this time, we have available in our department dual energy CT. And we can see the mineralization, subtle calcification on the conventional CT images within the tophus, and the dual energy CT shows extensive deposition of urate crystals in multiple locations around the knee, and a diagnosis of gout was confirmed. So gout is a metabolic disorder which leads to deposition of monosodium urate crystals in the joint and soft tissues. And we see this typically more often in men, and often presenting between the ages of about 40 and 60 years of age. Most often they present with arthropathy in the smaller peripheral joints in the hands or feet. But the knee is the third most commonly involved of the larger joints after the midfoot and ankle. But it's not usually the presenting site. The diagnosis of gout is typically based on clinical presentation and laboratory findings, and not usually based on imaging findings. And the radiological findings often take 5 to 10 years to develop after initial clinical presentations. The vast majority of patients with gout have that diagnosis confirmed clinically before they come to radiology imaging. We might start to see some more of these unusual cases for a variety of reasons as our population ages. Gout is becoming a bigger challenge for us in society. And with better treatments for rheumatoid arthritis, for example, we're seeing less of the advanced disease of RA and certainly fewer hospital admissions. And this, I thought this was an interesting graph just showing the burden of hospital-related admissions for arthropathy comparing gout and RA over the last 20 years. So the tophaceous component of gout presents as a chronic phase of disease. It certainly can occur around the knee, and when the tophi develop, they can involve any location, including in synovium, in tendon, can involve a destruction of the cartilage and be intraosseous in location. They have somewhat of a predilection for a peripatellar distribution. That's the most common site in and around the knee, and that may be associated with an erosion. And in fact, gout is well known to be a cause of a solitary lytic bone lesion in the patella. You should consider gout for a solitary bone lesion involving the patella. The MRI certainly can be helpful in suggesting the diagnosis, but the tophi can be somewhat hard to see because they're homogeneous to low signal on T1, and the T2 signal is highly variable. It's typically heterogeneous, and it's more often low signal, but it can have some high signal, with the degree of high signal depending on the degree of cellular tissue surrounding the crystalline mass and the extent of inflammatory reaction. But there may be very little inflammatory reaction to some of these tophi. The diagnostic accuracy of MRI for gout is very unclear. Here we see an example of some research that was done that's comparing MR with CT and DECT. And in this sort of cadaveric research, you can see the DECT shows the urate crystals beautifully, and you can see the tophi and the destruction of bones here. But this is a situation where the diagnosis is known before you do the research. And so it's a more challenging diagnosis when the clinical information is not presented to you as a suspected gout. In general, the diagnosis is best confirmed by a joint aspirate of monosodium urate crystals, and now in more recent years, dual energy CT is fantastic for showing the crystal deposition, and there are many publications showing that it's very sensitive and very accurate for that diagnosis. So these two cases were rare in the sense that the first one was very young. He was only 26 years old to present with tophaceous gout in his knee, presenting as a combined bone and soft tissue mass, but it is possible. Tophi was the presenting feature in both of these cases. Again, that's a less common presentation of the disease. As I said, in the first case, it had both bone and soft tissue components. And in the second case, it's very unusual that he goes for 6 years with a solitary tophus on the lateral side of the knee with this chronic knee pain without ever presenting with any other site of arthropathy in the body. So it's a very unusual progression of gout in that older patient. So deeper tophi can be very difficult to suspect clinically because they're not palpable and they're not necessarily particularly sore. The tissue signals and inflammatory reactions are highly variable. The degree of crystal deposition and calcification is variable, and there's a variable degree of bone involvement. So the MRI can be very challenging for this diagnosis in some cases. And I just want you to remember that gout can occur at any age. It can present as a solitary lesion. The imaging findings are highly variable. And if you don't have a dual energy CT available, there's going to be the occasional case which is going to require a biopsy for diagnosis. And I have some references here for everybody to have a look at. Thank you very much indeed.
Thank you, Robert. There was one question in the chat box, but I think you have already answered it, Robert. So, but I have a question for Marcelo Bordalo. Do you know if there is any difference regarding the prevalence of vertebral fractures in patients with and with?
Sorry, Aline, you paused a little. Can you repeat the question?
Yeah. Do you know if there is any difference between regarding the prevalence of vertebral fractures in patients with and without structural changes in the SI joints?
Yes, the structural changes are crucial for the increase of risk for fractures in these patients. So they act, as I said, as a longiver arm, and it is crucial to have these structural changes in the spine. So patients without structural changes have less risk of fractures in these spondyloarthritis spine cases. Yes.
Okay, and also, considering the vertebral fractures in SPA may not usually present with the clinical signs and symptoms of an acute fracture and may be overlooked when back pain is interpreted as a disease flare of SPA, when do you recommend imaging the patient and what kind of diagnostic method would you choose? I know you said when there's a history of trauma, you pick CT, you choose CT, but sometimes these patients don't have a history of trauma. So what do you recommend?
Yeah, it's interesting. In some cases, we had a case, the dish case, was 3 months after the trauma, he did the diagnosis. So it's very difficult to manage these cases if the patients don't help on history. So not always the trauma is obvious. It's a minimal trauma. So it's very difficult to make the diagnosis. That's one of the reasons that there is a delay in these diagnoses. And I think if we have a history of trauma in a rigid spine patient, I think it's mandatory to do a CT to rule out a fracture.
And in case you don't have?
Sorry?
And in case you don't have a history of trauma?
I think a change of the symptoms, the kind of pain, these patients usually have chronic pain. So a change in the kind, the type of pain, maybe that's an indication. I'm not quite sure if without a trauma, what would be an indication. I think that's a good point.
Okay, thank you. Let me see if there is any other question here. Yeah. You have a question?
I wrote it in the chat box, but I wanted to thank Winston for his wonderful presentation. And just to mention everybody, we had 2 cases of mesenchymal phosphateric tumors in Edmonton, and they're both initially PET negative. The first one was a patient who had a lot more hair than Winston, and he had a lesion right at the apex of his skull. And so the PET went from eyes to thighs, and they just missed 1 or 2 inches of the apex of the skull vault, and that's where the tumor was. The patient didn't even know he had this lump. And the second one, the tumor was in the mid-tibia. And so again, it was below the extent of PET. And because the way PET is acquired, in some malignancies, they will not necessarily go much below the knee, depending on the indication for the PET. So for that particular tumor, because it can occur anywhere in the skeleton, including in the toes, you must include the entire skeleton in that PET.
Thanks, Rob. That's quite a valid point, because the purpose of putting the PET-CT into that context of the case presentation was that what one considers artifactual and pooling of radionuclide, one needs to assess very, very carefully in the case of phosphateric mesenchymal tumors. The old thinking was that these occur only in the sinuses, skull sinuses, but now one realizes that they can occur anywhere. I've got cases in the feet, in the knee joint, in the soft tissues, as you saw in the forearm, and in the rib. So functional imaging is useful, but is that the only method of use? No, it's a careful clinical thorough examination, looking for lumps and bumps and swelling, measuring of FGF23, so putting them all together. Very much like in spondyloarthropathy, there isn't one magic test. You've got to put everything together, and it's the art of medicine at the end of the day. Thanks.
Okay, I want to thank everyone, and I'm looking forward to the next session. See you in August. Bye-bye.
Bye.
Bye, everyone.
Thank you.
Thank you.
Bye-bye.
Bye, Rob.